today we have Adam Devaney. He is a licensed clinical social worker with Life's Work Clinic here in Kalkaska, and he's going to talk to us about his clinic, medications for opioid use disorder, and the misconceptions related to substance use disorder and medications for opioid use disorder. Take it away, Adam.
All right. Well, thanks for having me. And so Life's Work Clinic, right, was the brainchild of my wife and I. After experience working at two other clinics previously for several years as employees, and when those ended, then and we opened Life's Work Clinic. It was the natural result of that, and so it kind of happened organically. You know, my wife and I were working with a doctor who was doing pain management, and through that experience, actually, we figured out that the real need in the world was for opioid addiction management. And so it was sort of an organic transition that way. Life's Work Clinic does three things. We do medication-assisted treatment for opioid use disorder. So we use drugs like Suboxone, Zubsolv, Subutex for pregnant women to manage the physical part of the physical dependency on opioids. Then the behavioral health component comes in. The behavioral health component is there to address the behavioral issues and the disruptive nature of the lifestyle, of the behavioral patterns, of the struggles with anxiety, depression, trauma, things like that really feed into addiction, whether it's for opioids or other drugs. Although we do find that, the holy trinity, as I call it, predisposition to opioid use disorder or developing opioid addiction, of course, is, anxiety, depression, trauma, some combination of all three, and then some extra ones. And then the third thing that Life's Work Clinic does is we're actually working with our supervising physician right now to bring him on to do psychiatric work as well. Because one of the things that's really in need in our area, in the Kalkaska area, in the sort of 50 miles that surround that, you've got Traverse City, you've got Petoskey, there's some psychiatrists in each of those, but you've got this kind of no man's land from Traverse City over through Kalkaska, over to Grayling, and beyond that, down to areas like Houghton Lake, Roscommon, even Cadillac would pull a lot of people from there. Since there's really we know that there's almost no MAT or medication-assisted treatment in that area I just described. But even more so, and I think more critically, there's a lack of psychiatric services in that area. A lot of primary care physicians are offering psychiatric services to their patients, and that's fantastic. If you have an MD or a DO, you can prescribe those drugs. But at the same time, having someone that really specializes in that and has that experience in that, really, I feel is going to be a huge benefit to this area, because over the course of the last 15 months, 16 months, right, we've gone through some pretty dramatic changes in our society. As we know, opioid overdose deaths have skyrocketed over that time. It's really some grim figures that I don't even need to express to anybody. It's pretty horrible. But at the same time, you have, like we spoke to an ER doc about 2 months ago, who said that 1 out of every 3 people that are coming into the ER are coming in for panic attacks. That's 1 out of every 3. That's 30% of people that are going to the ER are having panic attacks. Why is that? Well, our whole world changed. Our whole world collapsed in many, many ways. People are isolated. People are lonely. People are fearful. And because of that, what's happened is there's a huge demand for behavioral health and psychiatric services. More so than ever, and at a time when services are not expanding, when they're actually contracting. But at the same time, there's been a very innovative trend towards the use of telehealth. So I would say that probably 75% or more of my clients that I see for counseling are done like this on their phone in the comfort of their own home. They don't need to leave their house, and so also many payers, many insurance companies have adapted this to this reality, and so there's kind of like on par our payments for providers, which is really nice, which encourages that. So our psychiatric services are going to reach to other people just like in outside of our area, just like our behavioral health can, and just like our MAT can. We have people from Kalkaska in our medication assisted treatment program. We have people in the UP in our medication assisted treatment program. So really branching out and reaching out to where the people are. And right now they're in their homes. Right now they're not really going out. So that's kind of the background of the backbone of what Life's Work Clinic is. And we're really just trying to meet a need in our area in very, very specific and important and hopefully, and I believe, life-saving ways. Now, what you were talking about what some of the myths might be of addiction, right? And I kind of already touched on a little bit of the predisposition factors for addiction: anxiety, depression, trauma. Those are the big ones, right? And when I was really young, when I was a young psychology student, I was like 21, 22 years old. I met this clinical social worker, and he told me, he says, in my practice, I just figure sick people use drugs. And I was like, well, that's interesting. He's like, when you're sick, you use drugs, right? He's like, when you got an illness, you go to the doctor, they give you drugs, you get better, right? So he said, when I find someone with a depressant addiction, so they're addicted to alcohol, they're addicted to opioids, right? He says, I always look for an anxiety disorder because they're medicating in the opposite direction that they're suffering. So if someone's got really bad anxiety, they're going to drink to try to stuff down that anxiety. They're going to take a pill. They're going to shoot heroin, and do something to go in the opposite direction to quell that anxiety. He says, if I find someone that's using, say, cocaine, right, or speed, he says, I'm gonna look for some sort of a depressive disorder. Okay, because again, they're feeling already low and they want to go in the opposite direction. And I thought, I chewed on that for a long time, and I didn't really get into, clinical social work until much later in my schooling. But then, I just keep going back to that conversation that I had with that guy where, like, he was spot on. Like, he just nailed it. Like, people are self-medicating. People are self-medicating with drugs. People are self-medicating with food. People are self-medicating with behaviors, which really creates an expansive definition of the potential for addiction, which is that, is your adaptation becoming disruptive to your life? Because that's the real definition. If we look at the textbook definition of addiction, it really is not an issue until it's beginning to negatively affect someone's life. And at that point, you've got a clinical diagnosis. So when people, our approach really is to sort of bust these myths that there's something wrong with the person, that there's something that is, that it's a moral failing, that it is a, something beyond the fact that human beings are just trying to find balance in their life. I just, sometimes it's about getting people on drugs. Sometimes it's about getting people off drugs, right? Sometimes you can get people off drugs by getting them on other drugs. There's a balance to be had there. For example, I have a guy, he's not in our addiction program, right? He came to me, 39 years old, and he's really struggling with kind of like what kind of presents like a sensory disorder. Like he's just really he has like a quick startle response. He has to have earphones in when he does his work or goes into any kind of store or anything like that because it's just too overwhelming for him. What I got when I was talking to him was that he used to be treated for adult ADHD. About 6 years ago, when he started having kids, he thought, well, I don't want to be on any of these drugs. I'll just go off these drugs. Right. So he went off the Adderall. Well, what ended up happening was he had these classic symptoms of, especially the startle response. Like if he's really actually like finally focused on something and someone comes up and taps him on the shoulder, he's just like, not being able to walk into stores. Like grocery stores, things like that, because let's face it, if you have adult ADHD and there's like a million stimuli in a store, right? He was completely overwhelmed. So of course, as a behavioral therapist, my first work is, I teach him how to ground, I teach him how to meditate, I teach him how to calm and center himself. Right. And when those techniques didn't work, we started discussing whether or not it might be relevant for him to attempt to go back on the extended release Adderall. Well, a couple of weeks ago, he came in and he's had talked to his primary care physician about getting back on the extended release Adderall, and about 70 to 80% of his symptomology went away like that. Wow. Now, it's a controlled substance. Okay, so you do have to, be concerned about those things. I mean, there is potential for abuse in anything like this. So, you do your due diligence. You run a MAPS report regularly. You do, you check on people. But in this particular case, I met with him again yesterday, and he's just about got it all managed, and he probably needs to go. We figured yesterday probably needs to go from a 20 milligram extended release to a 25 milligram extended release, and that's going to work really, really well for him. So sometimes you get people on drugs, sometimes you get people off drugs. Sometimes you get people on drugs to get off drugs. And this is where our philosophy really varies quite a bit from the traditional abstinence model. We understand and accept that when people are ill, they use pharmaceuticals to help with that illness, whether that's emotional, whether that's physical, that connecting the person with the right practitioner that can allow them to find that balance through that is just as good as getting somebody off of the drug of abuse and helping them find balance that way as well. And that's some of the myths.
Yeah, it's there's a lot of stigma towards people using medications to help themselves emotionally, but yet there's not stigma for people, taking medications for diabetes. It's I don't know.
That's a fascinating thing that you just said, actually, and that's a conversation I have with a lot of our opioid addiction patients, and I actually have on our website, lifesworkclinic.com, there's a blog, and one of my papers that I wrote on there was, questions and answers on buprenorphine therapy. And one of the first questions is, well, aren't you just, substituting one drug for another? That's like a common thing. We actually hear it a lot from family members of people who come to see us. And the answer to that question is pretty simple. Well, yeah, we are. Okay. One has the potential for abuse. One does not have the potential for abuse. One destroys a person's life, potentially. Another saves a person's life, potentially. So, and the conversation I have with my patients so that they understand this is when they get on this drug, it's a lot like someone managing their type 2 diabetes. If somebody, and this is my example, if somebody eats McDonald's every day for 20 years, right? Sometimes twice, okay? And they go to they're 100 pounds overweight. They go to their doctor and they're like, man, I just don't feel right. My mood is terrible. I just feel exhausted all the time. And so the doctor runs some tests, and it turns out that the person's blood sugar is 400. Doctor says, look, bottom line, you've developed type 2 diabetes. You broke your pancreas. Okay. So the doctor says, this is what we're going to do. We're going to get you on metformin. We're going to get you on insulin. I want you to stop eating McDonald's, and I want you to do a little bit of exercise. We'll start walking around the block a few times. Then we'll, up the exercise, etc. We can take care of this. Okay. So the patient comes back in a couple of months later for a follow-up. Blood sugar is down to 200. They lost like 10 pounds. They're doing great. Doctor's like, fantastic. We'll continue the metformin and the insulin, continue to, avoid McDonald's and increase your exercise. Okay, fantastic. Two months later, they come in, blood sugar is 350 again. They smell like the McDonald's they had on the way there. Clearly what they've done is relapsed, right? And the doctor says, okay, so this is what we're going to do. We're just going to start back at the basics here. We're going to keep you on the metformin. We're going to keep you on the insulin. You're going to stop eating McDonald's, and you're going to start exercising again, right? Because what ended up happening, I'm not sure, I just lost your, wait, did I lose you?
Nope.
Are you still, okay, all right, just lost the video, that's fine. And so what happened with the person with type 2 diabetes is they literally, through a series of long-term lifestyle choices, basically broke their pancreas, okay? Their pancreas cannot to no longer keep up with the blood sugar. There's fat in the blood, and they just can't, the pancreas is just broken. So you need the metformin, you need the insulin, right? You can manage it, you can get that down to 200, right? But you're still, you stop eating McDonald's, you start exercising, that's fantastic. But the bottom line is actually damaged a part of your body. So it's gonna take some medication to treat that. For some reason, and I don't advocate for stigma on that, but we don't put any stigma on that. Okay, we're just like, oh, person's got type 2 diabetes and it's being managed, right? So what happens with, let's say, opioid addiction? What happens is every time that a person takes opioids, right, the potential is there for the next time that the cell reproduces, for that cell to reproduce even more of the receptors, for the opioid receptors. And so over time, you get a lot more of those receptors. You build a tolerance to the drug. You become physically dependent on the drug. You need more and more to get the same effect. What's happened by the time that they come to us and they say, I've been doing this for 15 years. I've been injecting fentanyl, 5-6 times a day. What happens is that when they don't have that, their cells are screaming, right, for that drug. And those receptors, what's fascinating about those receptors is that if there's no other opioid present, those set of 7 different types of receptors are actually busy regulating your hormones and your neurotransmitters. And that's why people feel so terrible when they go without it. When they go into withdrawal and their hormones and their neurotransmitters get out of balance, it's just horrible. And we can see that in all the effects of the, we just tick off the effects one by one on the clinical opioid withdrawal scale, and it's not pretty. So when someone comes to us and they say, well, is this going to fix me? Well, no. What buprenorphine is going to do actually is it's a partial opioid instead of a full opioid with that extra part that inspires the body to produce more and more and more and more and more receptors. It's a partial opioid. So it goes in there and it just manages the withdrawal. It just occupies all those receptors, and the person, fixes it and forgets about it for a 24-hour period. And then, of course, there's most of the drugs we use have naloxone in them. So the naloxone slowly goes in there and fills all the others, which then it acts as a blocker. And then, of course, it helps to prevent overdoses if somebody does relapse. So a really fantastic drug. What's fascinating to me is when someone will go on a buprenorphine for a few months and then they just decide that they don't need the program anymore and they just quit, right? And then they inevitably call us up and they're like, you didn't tell me there was going to be withdrawal from this stuff. Okay, let's start at the beginning here, right? You came to us with a raging opioid addiction, right? We told you we were going to manage that. When you stopped taking the drug that we were using to manage it, right? You went right back to the level of physical dependency and withdrawal that you were going to go through before you came to us. It's the same thing with the person who has the damaged pancreas because they develop type 2 diabetes from eating McDonald's every day. You know, if they don't take their metformin and their insulin, they're still going to have a 400 blood sugar pretty much like as a given, because they simply can't process that. So we manage that, but the key component is this. It's the behavioral health care. It's the fact that you see a counselor sometimes weekly, bi-weekly, or monthly, so that you always have someone to talk to. You always have someone to help you work through the anxiety, the trauma, the depression. You always have somebody to contact so that you can work with that person to address the mental health issues, which were really driving the need to use something powerful as an opioid to suppress those tendencies in your emotional health. And so that for us is the key. Like I tell people that's like 75% of it. Like the drug is like maybe 25% of it, works really great, it's fantastic. But the rubber meets the road when you start getting into the mental health aspect of it, and you really start connecting with your counselor, and you really show up, and you really show up to do the work. That makes all the difference.
Right, and they can't, if they were not to take that medication and they were just to go into counseling, because of the way that they feel, it would be hard for them to focus on the counseling part of it until they feel better. Right?
And that's the challenge. That's the particular challenge of, and I'm not bashing abstinence only programs. Okay. I've known many people that they've helped. They don't work very well for opioid use disorders. They have about a 6% success rate on that. Okay. Alcohol, gambling, sex, things like that. Those are, you know, abstinence programs work very, very well in getting to the core of those issues and really helping people heal. With opioids, if you go through a 7-day detox program and you do a 21-day stay in an abstinence-only residential program, you are still in subacute withdrawal by the time you get out of there. So what's the first thing you do? You call up your guy and you get a fix. And then you enter into the really, really, really dangerous zone, which is the 3 biggest risk factors for fatal overdose upon relapse, which is completion of a detox program, completion of a residential program, completion of a short stint in jail. Because your tolerance dropped. And you're like, well, I'll just start out at somewhere near, you know, where I was before. And then that's where you see a lot of the really sad, unfortunate, you know, fatal overdoses upon relapse, because, you know, they successfully completed, you know, some sort of program that our society really encourages, and that does work for some drugs, but for opioid use, not as well.
You have to question how much are they getting out of, if they were to come into you and just want counseling and not have that medication, how much are they actually getting out of the counseling when they can't focus, they don't feel good, you know? It would take quite a while, and more than likely they're not going to be able to make that. They're not going to be able to focus.
Yep, exactly. So that's where medication is appropriate, right? It's not appropriate to tell the type 2 diabetic, just go out there and diet and exercise, change your diet and exercise, without giving them the support of metformin and insulin. So, you know, that's where the judgment, the stigma of medication assisted treatment for us just falls away. It's just useless. It works if a person works the program and shows up and they're ready to do the work. It really, really works. So you got with the abstinence programs, you got about a 6% success rate. And with medication assisted treatment, if you stick with it for a few years, you actually have up to about a 60% success rate, which is a tenfold improvement. And that now you're really standing the chance of saving someone's life. And not that abstinence programs don't work. Sometimes they do. Okay. I have a builder that I'm working with right now on a remodel, and 6 years ago, he went into rehab, and, you know, he was using heroin at the time. 6 years ago, he went into rehab. It totally worked for him. He never did it again. And he's got a successful business and a family now, and he's really doing well. So for some people, it does work. For a lot of people, it doesn't work. So we're there for the people that say, hey, look, I tried a residential program a couple of times. It really didn't work for me. It's time to try something different.
And I've heard that the misuse of these types of medications aren't any higher than the misuse of any other prescription medications.
You do run the risk, if you have prescribed someone, instant release Adderall, that they crush it up and snort it, right? You do run the risk of, people overusing their Suboxone. You do run the risk of people diverting, their Suboxone. Very few people come to our program who haven't, tried Suboxone on the street beforehand. So we are aware of that. And we do have some mitigation policies and some diversion control policies in place. There's very few things that will get a person kicked out of our program, diversion being one of them. Okay. The other is, being completely belligerent and obnoxious in our clinic or by phone. Other than that, we're pretty accepting of people. We understand. Unfortunately, relapse is part of the process. And I think by busting the stigma and just eliminating the stigma and the judgment entirely, and really approaching people with a level of neutrality and acceptance for what's going on with them, what we find is that when people fall out of the program, they do typically call us back up and get back in. And that says something about the approach. There's no, if you had judgment, if you had stigma at that point, people wouldn't feel comfortable coming back. And I think that that's where a lot of practitioners, can kind of do some harm. If someone feels like there was judgment or stigma in the program, they're not as likely to go back to that program.
So we have a huge increase of meth use in our area. And a lot of these people are also on opioids. Can you say something about those issues?
Sure. So meth is a really fascinating animal. And I've got about 3 minutes left before I got to go to a client. But meth is an interesting animal. Methamphetamine is chemically similar to, molecularly similar to amphetamine, which is Adderall, which is your common ADHD medications. So there's a certain percentage of people who use meth that are literally self-medicating, just like that other guy said to me before. So I would add to what he said all those years ago and say, if someone comes to me and they're using methamphetamines, the first thing I'm going to assess for is adult ADHD. So, my clinical experience tends to be that it's about 50 to 60% of the people that are using meth are really kind of feel normal when they do it, because they should be on some sort of an Adderall or a Ritalin or something like that. So there's that aspect of it. There's another 40 or 50% of people who use meth because they really get it's a stimulant. Right. So again, they're depressed. They really want to feel high. They really want to feel, stimulated. And so methamphetamine provides that. Unfortunately, it's a very dirty drug. Unfortunately, it's a very deadly drug. And unfortunately, it's a very inexpensive drug. So those things are difficult to overcome. Typically, when people are also using meth and they're in our program, those are the people who don't typically last very long in the program, because is this concept called what I call priming, right? Like if you're constantly using a mood enhancing drug, even though you're in a program, right, kind of priming yourself. It's sort of like every time that I quit coffee and I would just drink decaf. Right. It was kind of like I was priming myself, and then I would start putting a little bit of caffeinated in there. And then before you know it, I'm up to 3 cups of coffee again, full flavor. So there's a little bit of priming that goes into that. So we have not seen as much success with patients who are using both meth and are opioid addicted in our program. Some people have stopped using meth entirely once they got into our program, but again, it's a little bit of priming that goes on, and meth is a little bit more insidious like that. I'm not really sure. We haven't really cracked that code yet, But I think that if people were serious about recovery, they could get on an extended release Adderall or something like that under a prescriber's supervision. And I think about half of the people would probably do pretty well on that. But I'm probably 30 years ahead of my time on that.
Does anybody else have any quick questions for him?
No, I'm glad you brought that up, Suzanne, because that's what I was wondering about, what's the promising outlook for meth addiction?
It's a tough one. There's no replacement therapy for that, except for ADHD medications and supervision in that way. So it's a promising thing, but it's also something that's not FDA approved. It's not something that insurance is going to cover. So there are, as I said, I'm probably 30 years ahead of my time on that.
Right. There was a combination too. What was it? Vivitrol and Wellbutrin.
Yes, exactly. That I thought was very promising.
Interesting. Yeah, Vivitrol. It's really a broad spectrum drug therapy approach. Works for alcoholism, works for opioid addiction, and so what Vivitrol does is it blocks part of that pleasure response that people get when they do drugs.
And it works for meth as well. Doing that.
I haven't heard that, but it would make sense.
Okay.
That's what I read on, and Wellbutrin works in the same way. Wellbutrin is the drug that they use to prescribe to help you quit smoking, so it blocks some kind of receptors too. So
it increases dopamine a little bit.
Yes, it's the dopamine response. If you can block the dopamine response in a person, then whatever drug they're using becomes less and less attractive over time.
Right. Well, thanks. Can you have anything to ask Molly?
Well, it sounds like you have to go see a client. I don't want to hold you back.
Go ahead.
I really appreciate everything that you're saying. The only one thing that does come to my mind is there have been many concerns expressed to me. I work in prevention with Suzanne, and there's been concerns expressed to me related to the diversion of these, of Suboxone and things of that nature. And so I'm just curious. I mean, you already kind of touched on that, but I think that is something that people are resistant to as a result of that potential diversion. And so I'm curious, I guess, if you want to expand on that at all.
Sure. So one of the things that we do is a random pill counts. So we'll just and nowadays it's really fantastically easy because of all the virtual stuff. I can literally call somebody up and have them go like this with their strips, right? Or I can have them, quick send a picture, via text or something like that, or have them go to the pharmacy, do that. And so, pill counts are a really useful tool in that. And we do the pill counts literally at every appointment. So we like to think that we're on top of the diversion. We definitely have a lot of different aspects to our diversion control policies, but there's no perfect answer for that. Mm-hmm. All I can say is I've got 2 people in our program, actually 3, 4, half a dozen people in our program right now that we're paying $20 to $40 a strip for Suboxone from a buddy of theirs for a year or more before they got in our program. And the thing is that those people were actually stable. Yes, they were getting Suboxone off the street. Yes, unfortunately, someone was diverting it to them, right? Mm-hmm. And clearly their doctor was not on top of their pill counts and things like that. But once they get into the program and they, one of the beautiful things that happens is their insurance starts paying for it. These tend to actually be, what's really fascinating is those patients actually tend to be the least likely to relapse in our program. Mm-hmm. Because they've already experienced they already know what it's like to be more or less stable on Suboxone. Now, typically when they're getting that on the street, because it's so expensive, they're typically taking less than they actually need to be stable. Mm-hmm. So the diversion, getting it off the street it's not an ideal situation for people. So some some MAT programs will deny people access to their program if they call them up and say, I've been getting Suboxone on the street for the last year. I really want to be part of a program. A lot of places will actually say, I'm sorry, but unless you get a doctor to actually refer you, then okay, it looks like my client has been sleeping off cold today, so we got a little bit more time. So then that to me is like really offensive. That's just offensive. I'm in the business of helping people, right? I'm not in the business of putting up roadblocks for people. And if people are honest enough with me to say, hey, look, I've been getting Suboxone on the street for the last year, right? I'm like, well, come in our program. We're really going to accelerate your recovery. So diversion, another thing that we do in our program is we always have people on what we consider to be the minimum dose that they need. Our induction process is very thorough. So when people stop having clinical withdrawal in the setting of the induction, that's it, they're done. Like that's their dose. So if that stops at 1.5, they're just at 1.5, right? And so some other doctors, and and everybody's free to run their practices the way they want to, but some other practices, what they do is they just simply start you out at 3, which is the ceiling effect. There's no more effect past 3. I feel like what happens in that is you're setting people up for diversion. Someone realizes, well, we only need 1, and they can sell 2 a day, and they can pay their rent, right? So some diversion control policies are just simply logical, like keep someone on the minimal dose to keep them out of withdrawal and to manage their cravings and no more. That helps to tamp that diversion down because the person only has enough to work for them.
That makes a lot of sense, and that's really helpful. Yeah, thank you.
Of course.
I know you're not, prescribing it yet, but can you talk a little bit about Sublocade?
So Sublocade is a brand new thing. Some practitioners really embrace it. So if you show up with a bad pill count or you show up with a dirty tox, right? They'll basically just come into your appointment and they'll say, okay, this is your option. You're either in the program and you're getting Sublocade or you're out of the program. So Sublocade is a time-released, 30-day time-released buprenorphine and naloxone. So it's an injection. It's a 30-day time-release injection of Suboxone. It's the same company. I have mixed feelings on this. First of all, it's a 30-day injection, which means that if a person has an adverse reaction to it, they're stuck with it for 30 days. I don't personally feel comfortable with that. Second, the reports we seem to be getting from patients, is that it's a little bit euphoric for the first week, stable for 2 weeks, and then minor withdrawal for the 4th week. So from a clinical standpoint, the reason that we don't use Sublocade in our practice is that that's not considered stable.
I've heard some clinics actually give some Suboxone those last few days because it was day 26 or 28. It really starts to drop off. So they have to give some Suboxone up until they get their next shot.
Right. And then you run into the challenge of, is the insurance going to pay for that?
Right.
And so, then you run the risk at the end of that cycle of a person just simply relapsing every single month. So, and then of course there's the warning, the black box warning type warning on that says, hey, one of the potential side effects of this is death. And I don't really want to have someone come into my clinic, get a shot and die.
Right. Yeah. I also heard that you are providing MAT for people who are in our local jail, for people who are already in your program if they go to jail.
We haven't had we have a pretty good relationship with Kalkaska County Sheriff's Office. We haven't had an opportunity to actually do that yet.
Okay, but they're willing to do that.
They're willing to do that. They've met with us. They're willing to do that. We just simply haven't had an opportunity to do that yet. In fact, but there have been patients of ours that did short stints in other counties where they were given that.
Okay.
So some counties, Benzie County, I think Leelanau County does that. Grand Traverse does not. So it's kind of a patchwork right now, and it's really up to the jail administrators as to whether or not they want to do that. You know, Sheriff Whiteford's opinion was basically if somebody is withdrawing in his jail, that's more risk than giving them Suboxone.
Right. That's awesome that things are changing, because I know a year and a half or so ago, personal experience of someone detoxing on their floor from their Suboxone. So, which is
right, not a good deal.
Not a good deal. No.
Mm-hmm.
So that's great that things are changing. So.
Yeah, they are. It's county by county, but it is changing. In fact, mentioned Vivitrol earlier. The Michigan prison system has a Vivitrol program now, where they it's not 100% effective in the sense that they do tend to miss some people. But when you've had a few years in prison and you're about to get out, like the week before you get out, they'll actually offer you a Vivitrol shot. Because, you know, of course, that's one of the highest risks for fatal overdose. So that's really an awesome thing. And now that one thing that's about to change at Life's Work Clinic is that my amazing wife, Mandy, is just finishing up her MA program. So she'll be a medical assistant and we'll be able to do blood draws and injections and different things like that. So we will have some new options. We're going to get back on the Vivitrol referral list as well, because right now our practitioners are only contracted to come in the office, like, you know, Ron's in there like 2 days a month, and Rachel's always by video. And so Vivitrol just didn't work, you know, because if someone needs that and they get approved for that, they need that day. So having Mandy in the office as an MA, you know, registered and certified to do that is really going to be one of the huge game changers for us and the community.
Right. Awesome. That's awesome. Well, does anybody else have any other questions? Belinda?
I do have a couple of questions, meth related. My son has substance use disorder, Adam. But I just met some folks the other day too, out in Benzie, and all three of them are recovering addicts. And I just want to know where these folks get the idea that you cannot overdose on meth. Do you have any insight on that? And why did they use that as a shield? Well, it's not like heroin. It's not like this. I can't overdose on meth. Is there any truth to that, Adam?
Well, there's no truth to that. I mean, the bottom line is that the difference between medicine and poison is dose. Okay.
True.
And then of course, in the case of meth is a series of chemical reactions in order to make it. Not only is it a series of pretty significant chemical reactions in order to produce it, but it's sometimes cut. So, and I just want to throw this out. This is actually a great lead into the biggest issue facing, I believe, right, the whole drug using population in the United States outside of alcohol and marijuana. And that is cheap imported fentanyl from China.
Yep.
China, I'm just a personal believer that China is actively waging war on the United States. And one of the ways that it's doing it is importing this really, really inexpensive fentanyl. And it has been the source of like 3/4 of the opioid overdoses, you know, over the past several years. And you can see the graphs where in 2010, They reformulated OxyContin. That was no longer desirable. Immediately, you had a spike in overdose deaths from heroin. And then by 2013, China started importing the fentanyl, and the deaths, overdoses went like this.
Wow.
So big issue. The thing about meth is it's also one of the drugs that's subject to being cut with this synthetic fentanyl. So the idea that you can't, if it was pure methamphetamine, right, which is kind of a misnomer, I use that in quotes, pure, right, without an adulterant, cutting agent, it's possible that it has an overdose safety profile that's within acceptable levels for a lot of people. Certainly, it's more common for heroin to be cut with fentanyl and you not know it than meth cut with fentanyl, then you don't know it, or cocaine and cut with fentanyl and you don't know it. But it happens, and it happens more often than the general public realizes. So the safety profile of any drug that you're getting from the street, opioids or heroin, even opioid tablets now, you've heard about this?
Yeah.
They're being stamped with fentanyl, made with fentanyl. Meth, cocaine, all of these drugs now potentially are cut with a very potent opioid, and so the safety profile of meth, if you will, safety profile, is kind of a misnomer to use in a drug like that. That's all chemicals. The safety profile definitely goes down with the potential of being cut with fentanyl.
It does, however, cause heart attack, stroke. What else? It can cause seizures.
Yeah, irregular heartbeats,
Yeah.
etc. I mean, it's a stimulant.
Yeah, so overuse of it can definitely cause, you could have death from a heart attack or stroke.
Yeah, extreme weight loss, eating disorders, things like that. On top of the fact that with meth, one of the things that people do is they inject it and then they don't really get high until they throw up, right? So you think it's true.
Why
Many
is
people-
this? Because that would make sense. Between the two of these, she's always sick and not feeling well and throwing up.
Right, because meth can make you throw up. So, and that can have all kinds of secondary effects as well, like esophageal, disintegration, bad teeth, things like that. Another problem with meth is that it tends to the chemicals in it tend to replace calcium.
I've heard this.
So brittle bones,
Yeah.
brittle teeth, bad, really bad, skin. It can be really brutal on the body that way. So it's not a safe drug by any stretch of the imagination. It's a chemical concoction that is dreamt up in a lab. But it's also inexpensive, and people like that about it.
Especially the stuff that's coming in from Mexico, southern border.
Yep.
They don't make it as much anymore because it's actually so cheap to buy it, and you get less time if you get caught with it than you do manufacturing it. So,
And manufacturing it can be incredibly toxic to the environment. Entire homes where meth labs have been for in use for a long time, often literally have to be stripped down to the studs, and you have to start over. So, but my phone is about to die, so it just made that really, really sad sound.
but thank you so much for joining us. And like I said, this will be placed on our Facebook page. Portions of it, if not all of it, can be put on Up North Prevention's YouTube page. And we'll put it out there. Thank you so much.
Thank you so much. That was, super informative. Thank you.
Yep. And we will see you soon.
All right, take care.
All right, bye.